My name is Danny Lee. I'm the Marketing Manager here at Lumeta. I'd like to welcome you to today's webinar, Cybersecurity Drivers in Healthcare, Managing HIPAA and HITECH Compliance. Before we begin, I'd like to take a few minutes just to go over a couple of housekeeping issues. Our three speakers today are located all across the U.S., so there will be some transition time while we pass the control back and forth between the different presenters, so just keep that in mind. It should be fairly seamless, but just want to give everybody a heads up. Also, if you'd like to ask a question, please enter it in the GoToWebinar question dialog box right here. We'll be answering as many questions at the end of the webinar, but if we don't get to your question, we'll be sure to get back to you via email over the next couple of days. For today's webinar, our speakers are Skip Snow, Senior Analyst at Forrester Research, Katie Winslow, Director of Information Security at Catholic Health Initiatives, and Reggie Best, Chief Product Officer at Lumeta. And that being said, I'd like to now just give it over to our presenter from Forrester, Skip Snow, who will begin our webinar today. Over to you, Skip.
Thank you, Danny. Thank you very much for that introduction. And hello, everybody. Thank you for attending this webinar. And I am pleased to be able to speak to you about healthy communication networks in the age of the customer. Give me a second, sorry. Okay, so Forrester Research provides marketing and technology advisory services to leaders in sales, customer service and marketing, and technology management. Our mission is we help you succeed in a world where technology is changing your customers. I, myself, am a senior analyst. I focus on healthcare and technology management. I started my healthcare IT career in 1994 at Columbia University Medical School as an analyst and programmer. And I, myself, of course, am a part of the system as a patient and a member of a health insurance customer. We at Forrester have a theory that we're in the age of the customer. So starting, within the Industrial Revolution and leading up to the 1990s when we hit the information age, we believe that now we've entered a new age, which is the age of the customer. The idea, the fundamental idea of that is that the information infrastructure is essentially in place. The data is aggregatable. The tooling around the data and the processes and the automations are all sort of in place so that the voice of the customer and the customer journeys can be heard, and there are imperatives around in particular, we believe that the customer experience is key. And so in order to create that really important customer experience, it's extremely important as you consider the needs of your enterprise's network to understand that when your patients or members or customers or prospects are within your infrastructure, that they're going to be using your network and they're going to need to have access to your network, and also that they're going to be accessing the facilities and the capabilities of your enterprise via their mobile devices and other computing devices. And of course, as we all know, within healthcare, the amount of devices that are going to be used by your network and the amount of traffic that you're going to have to send out to those devices and the way in which you're going to have to manage the availability of the interfaces to those devices is now mission critical. I used to be the head of technology architecture at Kaiser Permanente. One of the things that used to happen when I was there is that if the system went down within the ambulatory world of Kaiser Permanente, we used to send patients home instead of treat them. Because of our dependency on the electronic medical record. We see that all the time within provider organizations, that the reliability of the network was often the cause of outages. And when those outages occur, there's a revenue impact, there's a care management impact, there's a cost to the health of the patients, and so on and so forth. So keeping those networks up and reliable is of urgent importance in order to support things like the mobile mind shift, which is another market imperative. So the idea is that everybody, 80% of Americans now have smartphones, and not only that, smartphones are more and more connected to monitoring devices and other mechanisms to ensure that the care facility is in control of monitoring and managing real-time signals from the patient community and, of course, from the staff of the provider community as well. You have to really understand that, as you all really know, that digital reality, the fact that the electronic medical record has now been digitalized, is changing everything about the way in which we deliver care to patients, the way in which we communicate with patients, and what our customers expect of us, our patients expect of us, our members expect of us. In other words, because there's so much change taking place around the fact that now the chart is available as a data source, there's so much disruption taking place that it's just really important to understand that having a clear and concise digital strategy is extremely important, and being available to execute that digital strategy from the perspective of your network is also extremely important. That turns to the question of the fact that a lot of the data sources that you're going to have are going to be from varied sources, and you're going to be taking feeds from all kinds of data sources. You're going to be moving data around your own enterprise in order to understand it and analyze it and act upon it. And so, again, it's going to be a burden on your network to rely on various software as a service data sources, cloud data sources, public data sources, as well as moving your own data around your own enterprises. The other thing that's, of course, happening is there's a great deal of M&A occurring, and in order to integrate already existing hospital systems that merge, there's often aggregation of data that takes place outside of the core systems, so that a patient, for example, moving from one hospital or ambulatory setting to another within an inorganic medical establishment, inorganically grown medical establishment, that the providers can see a uniform record, even though, in fact, they might be using different medical charts and different lab systems and so on and so forth. So these four market imperatives actually all translate within the age of the customer to more digital presence. More digital presence means there's more of a burden on your network, and the reliability and the absolute mission-critical nature of that network becomes more and more important. So, as we talked about, you know, the consumerization of healthcare is upon us. We see that in the provider industry, in which patient responsibility is so important, and working with patients to manage their own care is so important, and also because of the changing risk models, what we see is that engaging the patient at a level where they are more responsible to make good health decisions and so on and so forth is more and more urgent. We talked about how mHealth and mobile engagement is so important. And of course, we talked a little bit about the value system and how, in fact, the disruption is something that you're going to have to deal with at every layer of your organization, including the infrastructure and network layer. You're going to have to also deal with threats. You're going to have to deal with the idea that you've got a very porous network. And that's one of the disruptions, is that you're integrating with more and more partners, which exposes your network to more and more risk, and therefore understanding what's taking place on your network, not only from a perspective of what devices are using your network, but how those devices are using your network, and whether or not those devices are in fact, you know, attempting hacks and data intrusions. The more you know about your network, the more capable you're going to be of analyzing and dealing with the possibility of security breaches. And we've already talked about real evidence-based medicine is relying on huge amounts of data, which is moving all over the network. And again, that there can be leaks within your network of data that you really don't want to talk about. So again, we were just talking about the perimeter. We were just talking about the idea that in order to protect your network both as a security and reliability feature, understanding that your network is really porous and the perimeters really don't exist anymore, and therefore understanding what's taking place on your network in real time becomes more and more important. So we've talked a little bit about the mobile mind shift. I'm going to go back to that because, frankly, the telehealth revolution is powered by mHealth, and most provider organizations are really moving towards the idea that remote care is an important mode of both monitoring and treatment for patients. For example, most community hospitals are moving towards decentralized ICU care and decentralized radiology care, especially at night. Again, once you're starting to deal with these sort of remote care offerings, whether they're in the patient's home, whether they're in the patient's office, or whether they're with partners that you're working with, the reliability, the mission criticality of those things becomes really important. As you might know, as of December 2013, there were 40,000 healthcare apps in the iTunes stores. Curating them is a challenge. Trying to figure out how to work with them is a challenge. And making sure that you can service them with the reliability of your own network and the safety of your own network becomes a really important thing to do. One of the really interesting things about the use of mobile computing in healthcare is that there's a perception that, in fact, the utilization of the mobile is being adapted slowly. What's really important, and what you can see from this slide, is that what we see is the people who are at greater risk tend to use the system more and more than people at less risk. Now, what that means is that even though the adoption rates for using mobile to, for example, access your charts or try to make an appointment or try to figure out where you're going within a facility or the various things that people are using mobile for, even though the adoption rates of that are still fairly low within healthcare, what we find is the people who most utilize the system use those mobile solutions more and more. So the people who are sort of your frequent flyers, the people that you care about the most, the people who are actually giving you the most revenue, as well as, of course, the ones that you have to be most concerned about, who are at the most great health risk, they're in fact the ones who are using mobile more and more. So don't be fooled by the idea that the adoption rates are low, because the very people that use your system the most are using the mobile phones the most. And, for example, almost every hospital or contemporary hospital that's sort of doing advanced technology has guest networks, as well as provider networks, as well as employee networks, and you have to make sure that you manage and monitor those networks really carefully. You have to be able to shut down those networks if, in fact, there's any kind of medical urgency taking place where you're having network disruption. You have to be able to see that and cut the sort of superficial networks off in order to keep the critical stuff going. The slide that I've got up right now is just showing that, in fact, as you probably know, the results from remote monitoring and mobile health are that the outcomes are significantly better. And so there's a business case to be had around using mHealth. So the VA, for example, with congestive heart failure was able, in a study of 337, or I forget the number, I think it was much bigger, I think it was 70,000 patients, actually saved $9,000 per patient per episode of congestive heart failure. So it's really significant, the savings and the better outcomes that you can get by doing remote care. Again, to this notion of adoption, yes, it is true that the consumers are not adopting quickly, but it's also true, and very graphically represented on this slide, that the people who are comorbid are adopting much more rapidly than the people who are not comorbid. So again, that taxes your network more than you might think if you simply look at the adoption rates of mobile computing in healthcare. In terms of big data, again, the impact of big data on your network, you guys all probably know about, but the business cases behind that I'm going to talk about a little bit. So, for example, UCLA, by introspecting and doing retrospective research into their data warehouse with some of their leading physicians, were able to discover an interesting fact, and this is around muscular dystrophy patients. So the care protocol for muscular dystrophy patients is such that up until UCLA made this discovery within their data, that the density of urine was never a factor in trying to figure out what to do with muscular dystrophy patients. In fact, the incidence of urinary infection within muscular dystrophy patients is incredibly large, and they figured out that if once in a while, i.e. once per quarter, everybody with muscular dystrophy had a test for their urine density, they could reduce the rates of urinary infection within muscular dystrophy patients significantly. I forget the exact statistic, but I think they dropped it by over 35%. The point of this is the way in which they do that is they did it through retrospective research into their data warehouse. But in order to fuel that data warehouse, the amount of data that was flowing through the enterprise, through the UCLA enterprise, was great, and the demands were great. So making sure that that data could flow so they could do that sort of retrospective research became important. And again, the point is that the burdens of the network and the burdens of the infrastructure on that is great. Another incredible example where public data was combined in unique ways was at Memorial Sloan Kettering. So what Memorial Sloan Kettering did in order to create a test bed for some of the work they're doing with artificial intelligence and cognitive computing is they combined the CDC Medicare data for all people over 65 with the cancer registry data, the National Cancer Registry data, and they were able to create longitudinal records and actually figure out not only what was going on with each individual patient longitudinally in relationship to their cancer as it was registered in the National Cancer Registry, but also because they were able to map the Medicaid claims, the Medicare claims, to the cancers. They were able to get a much, much more holistic view of all of the interventions, all of the procedures, all of the billable events that were taking place for that population, and actually, have a great test bed to be able to map the efficacy of various things that they're participating in particular, an advice engine that they're rolling out to the care community. And again, in order to become a disruptor, you have to ensure your networks are reliable and secure first. And in general, the medical community is fairly conservative, so you have to really make sure that the infrastructure is in place before these programs, are rolled out, and that means a lot of these programs, which are sort of being led by the medical staff or innovation folks, they're relying on sort of a sort of dial tone within the network. But when those sort of reliabilities break down, then they're going to be hesitant to do the advances they need to do. And by the way, the data that we're showing here is around, whether or not folks are planning to introduce new and improved IT systems and so on and so forth, and whether the business models are changing. What this shows you is that, the vast majority of technology executives within the provider community are in fact introducing new improved IT systems, which burdens the network more. They're exploring partnerships with customer suppliers and other firms, which again creates a porous network. And they're changing the business models and moving towards the business models being more digital, with a little bit less intensity than the others, but still 41% are changing their core business models around risk and so on and so forth. And again, most folks who are changing their business models are doing it towards a much stronger digital presence, and therefore there's much more reliance on the networks. Devices, integrations are proliferating. We've talked a great deal about mobile. We've talked about the fact that medical monitoring devices, both within the critical care setting, within the hospital setting, and within the ambulatory setting, and within the home environment, are adding burdens to the network. The consumer health records are flowing all over the continuum of care. Medical grade repositories are all over the place, so that within health information exchange and so on and so forth, again, the information is flowing. And if those things break down, there can be serious disruption, especially, for example, around transitions in care. Institutions, as we talked about, are becoming more complex. There's a lot of activity in mergers and acquisitions. There's a lot more use of cloud than there used to be. I had a major hospital system in Southern California, the CIO, say to me recently, by default, we look to cloud for every solution that we are examining, and our default is to use software as a service or cloud solutions rather than hosting these solutions ourselves. This is a really huge shift that's taking place. Again, this makes the management of your network a more challenging problem and a significant, you need significant solutions in order to manage this. Again, hospitals are standing up health insurance companies. They're outsourcing, as we talked about, radiology and ICU. They're building large ambulatory practices in order to have more vertically integrated solutions. Again, it's all about, in fact, the institutions themselves become bigger and more complex, and how you manage that new complexity with the mission criticality of the technology systems really becomes, the network security and reliability becomes a really mission critical factor, and being able to sort of in real time see what's going on in that network and being able to put in place alerts and alarms around potential problems is almost an urgent priority. So what does it mean for you network managers who might be on this call? You have to consider real-time awareness of the devices. You have to ensure that you can see all the devices, both in the clouds, in the phones, in the staff-owned phones, and as we move forward within the wearables and within the Internet of Things. You need to manage the privacy of your network. You need to ensure that your guest networks are isolated from your employee networks and possibly isolated from the networks of providers that you have partnerships with. And you need to be able to audit that activity and report upon it and participate in the requirement that you detect breaches and so on and so forth, so that you can report accurately any HIPAA violations or anything like that. And as we've talked about again and again on this call, you have to manage the reliability a great deal. So putting it all together, in order to deliver the right care at the right time, at the right place, there has to be a combination of information and process. And in order to have that combination of information and process so that you can have an evidence-based environment where the data is giving you evidence of what's going to happen so that you can give the right care at the right time in the right place, and in order to create digital tools for workflow and process, the underlying assumption that the network is powerfully reliable and powerfully safe is something that is really, really going to be challenging everybody as we build these infrastructures of care that are really more and more digital as the future rises to meet the present. That's really all I have to say. Danny, I'm going to hand it back to you now. Thank you very much, everybody, for your attention.
Hey, thanks, Skip. That was great. At this point, I'm going to switch gears and give Katie the presenter control. And so, Katie, whenever you're ready, you can begin.
Yeah, good afternoon. Thank you. Okay, let me just present here. So I'm the Director of Information Security at Catholic Health Initiatives, and Catholic Health Initiatives, or we call it CHI, is the third largest nonprofit health system. We have approximately 96 hospitals in 18 states and have about $13.9 billion in annual revenue. We have approximately 120,000 employees, and we're growing, and we have a very large IT landscape to protect. CHI is in somewhat of a unique situation because we moved from being a holding company about 4 or 5 years ago now and chose to transition to be an operating company. And in doing that, we are consolidating and centralizing our IT from regional hospital systems and that used to be run all independently to really more of a centralized and regional model. So we've been working on consolidating our IT systems and trying to get the economies of scale that many tried to do by doing consolidation. And of course, that leads to a lot of challenges and a lot of unknowns. So today I'm going to talk to you a little bit about the 3 challenges that Lumeta is helping us with. First, I'll share with you about the challenges in our core operations, talk to you a little bit about our challenges in mergers and acquisitions, and finally I'll talk to you about how we use this information to prioritize our risks and do budget planning. So on this first slide, I show a lot of what Lumeta does, and for any of you that have looked at Lumeta or using it yourselves, you probably know a lot of this, but it's how are we able to really get the true visibility of our network so that we can use our core controls and security the best way possible. The goal of our security team, as many security teams, is to protect the confidentiality, integrity, and availability of our systems. But in order to do that, we really need to know what to protect. And as Skip covered just a few minutes ago, the threat landscape, the IT landscape is really changing in healthcare. And as I mentioned, our organization is really struggling with major growth and just being a very large organization, and then IT all coming together at the same time. We have a very big landscape to cover and to keep track of. So we also are challenged with our asset management and change management controls. It's such a large landscape to cover that we really struggle with. What are all the assets that we're trying to protect? How do those change, and when do those change? And with new introductions in the business, we don't want to stop what the business is trying to do. They're bringing phenomenal capabilities from an IT perspective into our organizations to really improve patient care and help our patients. But they're moving very fast, and they want to use these tools very quickly. So we need to be able to find those unknowns in our network and remediate the associated risks with what they're introducing very quickly so that those can really be a capability to help our patients and help how we deliver the benefits to our patients. So we really don't want to find these risks reactively. So oftentimes the way that, in the past we've found new assets on our environments or discovery of new egress points is through maybe an incident or an event of some sort or a problem, and we don't want to keep discovering those open items that way. So what we're using Lumeta to do is to really identify the gaps in our processes and building a baseline for asset management and change management, and really tracking very quickly how things change across our network so we can immediately fix those environments before the vulnerabilities are exploited, either on the assets or on the egress points. One example of this is that we used in our threat and vulnerability management with Heartbleed that came out recently. We used Lumeta to search our network for specific vulnerable configurations. Lumeta provided us with a search string. We were able to go and do that search, and we were able to identify the assets and quickly remediate those assets with making changes to protect us from Heartbleed. So another way that we use Lumeta is to baseline and monitor and improve our controls and our incident response. So really discovering, as I mentioned, our baseline for all of our assets, but also as that changes, being able to regularly update how we do our patch management, how we do our threat management, how we enter those new assets into our login monitoring programs, and be able to have all of the security controls we need to around those various products and IP addresses. The next challenge that we are faced with is, as I mentioned, we're rapidly growing. We're going through a lot of mergers and acquisitions. We do, I would say, between 5 and 6 a year of major hospital systems. So each one of those hospital systems have many different areas within them, whether they are they have long-term care associated with them, residential living facilities, community-based services, clinics, other physician practices. The landscape is just very big. And as we know, healthcare is going through this consolidation. And doing the mergers and acquisitions at the rate of 5 to 10 a year is extremely difficult, especially to bring in all of those unknowns that we need to be able to protect. So we use Lumeta during our due diligence phase, where we go into the new entity sometimes prior to purchasing, or after, maybe even immediately thereafter, and we're able to it's a very portable product. We can put it on a laptop, we can go out to the facility, and we can really understand what is our landscape, what are all of our IP ranges. We don't necessarily know how to scan the rest of the environment using tools like Qualys or Rapid7 without knowing what landscape and what IP addresses to put in those other tools. So we're able to go and really understand what is our landscape that we need to integrate. Post-acquisition, we also want to go in and rediscover, has that landscape changed? Oftentimes in a merger and acquisition, we have a great loss of resources, and there's a lot of knowledge capital that's associated with that. As those resources leave, we also lose the information of what they've been doing to support those environments for a number of years. I mean, we don't want to lose people, but just in changes that happen, it often works out that they decide that the organization is changing so much and maybe they move on. So we really struggle with understanding what is our asset landscape and what do we need to be able to protect and scan for. Also, it feeds our budgeting. So how do we need to plan for how much it's going to cost to take on that entity and to be able to budget to protect that entity and really look at the assets and determine, again, what is our asset landscape? Most of these entities don't have an asset management database, so we've got to go figure out what is the landscape and be able to protect it. And then we have this, then we feed the M&As back into the continuous process that we do in our core operations of regular monitoring, rediscovering, and understanding what's changing as the IT landscape is changing in the organization. The other challenge that I think many of us are up against is obviously budgeting and risk prioritization. So really, once we're able to identify what are all of those assets out there, what are all of our egress points, how do we better protect the organization, we can also better risk rank. Once we understand the full landscape, we can prioritize our risk remediation needs and what funding might be associated with that. If we really don't have a good idea of our full landscape, then it's very difficult to go back in and say where we want to spend money and what is the most risky areas that we have as an organization. So we really use this to identify those areas to invest in and to use the data to back and support those decisions that we're making. So we have many challenges as an organization to protect the confidentiality, integrity, and availability of our healthcare systems in this rapidly changing healthcare IT environment. And our goal is really to change and implement processes throughout the organization based on the data that we find so that we can protect the organization and our patients while still enabling the new technology capabilities that are coming out in the marketplace. And that's all I have. Thank you.
Great. Thanks, Katie. Appreciate it. That was a great insight on what CHI is doing. And just give me a second. I'm going to flip it over here to Reggie. And Reggie, it's all yours.
Great. Thanks, Danny. I'd also like to thank Katie and Skip for their insightful comments. Let me first kind of underscore a couple of key points which my colleagues made and relate to sort of the implications of some of the healthcare IT trends. And these are certainly things that we're seeing as we engage with organizations like CHI and others within the healthcare space. The point has been made that healthcare IT networks are large. They're getting larger. They're growing in complexity. Over the past year, I'd say that our average engagement within the healthcare space has been between 50 and 100,000 IP addresses, which is pretty significant. And those organizations are growing certainly embryonically internally, but they're also expanding via acquisition of new hospitals. There is absolutely a consolidation activity that's occurring within the U.S. in regard to hospitals merging, getting bigger, and some of them even, as we have gotten into the conversations about their networking concerns and their cybersecurity concerns, they're even branching into new businesses. I've talked to quite a few healthcare providers that are saying, hey, we're now going to get into the business of, providing insurance and insurance offerings within the healthcare space, which, we hadn't really seen as much before. Those will further drive this trend that we're seeing to networks that are growing and more complex. Certainly, and Skip hit this point, the number and variety of devices on the healthcare networks are increasing. Skip talked a lot about sort of the personal mobile, tablet, laptop, the more traditional mobile platforms that, are clearly being used within these organizations, and the disparity of networks, the patient network or guest network, the employee network. One of the interesting things that we're starting to hear more and more concern about, particularly at the thought leader, healthcare IT teams, is they're very concerned about the whole Internet of Things. There are medical devices, many of which are essential to life. They are life critical, which they want to understand, well, where are those devices? What are the patch levels? What are the location of those devices? Has a new device that I'm not familiar with, that I'm not aware of, is that on the infrastructure in some place where I don't expect it? So we've got a couple of the more advanced customers that are now trying to get their arms around the whole mission-critical, life-critical Internet of Things medical device that is oftentimes increasingly connected wirelessly to the infrastructure. And we expect that that's going to be a very significant area as we roll forward, and it's certainly an area where Lumeta is looking to provide more insights in an automated fashion. From an internal standpoint, it's interesting that many of the healthcare IT teams and cybersecurity teams, their initial interest is in our solution not so much for the internal network, where they believe they've kind of got it covered. Many organizations, particularly smaller ones, are saying, hey, I've done all this stuff for compliance, particularly around HIPAA. I think that, our network is kind of covered. We really understand what's going on that infrastructure. And one of the fears that we have, based on some actual data that I'll show you in a couple of slides, is that, that confidence may be a little bit misplaced, given our experience with what we actually identify on some of the internal network infrastructures in these healthcare organizations. When we first have an engagement, however, with a new organization interested in our solution, oftentimes they're definitely interested in the whole M&A thing and the networks that they're going to be attaching into their current infrastructure, and they are absolutely concerned about how we can provide visibility into the physician or the networks of their partners that they're engaging with to operate the business. And certainly some of the additional bite in the HIPAA HITECH fines and so forth appears to be a bit of a motivator behind wanting to understand those partner networks or these new acquired networks that are coming into the core hospital organization provider network. On the other hand, we've found that organizations like CHI and some of the larger thought leader organizations of that ilk do understand increasingly the need for automated methods of network situational awareness and vulnerability management. And in fact, some of those organizations are even becoming industry-specific managed security services providers to other regional providers within their territory. And that's a new and interesting kind of an occurrence that we've started to see over the year. So when we talk to healthcare IT shops, we generally tell them, look, there's a 20% gap, particularly on networks in excess of 10,000 IPs under management. There's a 20% gap in what you know about the network and what actually is going on in that infrastructure. And again, a lot of times, folks look at us like we have 6 heads when we say that, but once we get in and we start showing them what we've identified through the use of the Lumeta tools and platform and some of the foundational authoritative information about what's actually there on the infrastructure, this 20% gap is easily verified. Now, why is that? You've got the mergers, acquisitions, consolidations that, we've been talking about throughout all the presentations. And this stuff is changing. It's changing very, very fast. You've got the vendor connections, the physician network connections, and guess what? You've got rogue network infrastructure. Somebody comes along and plugs some new networking device into the infrastructure. Or you've got a team that is spinning up a cloud instance in AWS or some other cloud offering, and maybe they're putting in place a network function that's now virtualized in that cloud infrastructure or virtual infrastructure that you didn't necessarily know about. So this is all leading to, in the context of existing physical networks, the gap in network visibility. And our position is that that's only going to increase as networks get larger, and also as you see these migrations that both Skip and Katie have been talking about, from fixed devices and infrastructure to mobile. Things are coming and going very, very quickly, from physical servers to virtual servers, from the data center to clouds. And in fact, those drivers are going to imply real-time analysis as opposed to scan-based analysis. So this slide actually shows you just a couple of name-redacted healthcare organizations that we've dealt with. And when we started, there was an assumed number of devices on the network. Usually that comes out of a spreadsheet, or maybe it comes out of a vulnerability management tool like a Tripwire or Qualys that might be in use. But then once we go to work, in these particular cases, you can see the difference in the number of devices that we actually found by crawling the network that were there and in use and live. And you can see the number of unknown networks. These are networks that weren't in the original target list that we were provided. So they were not being managed by any vulnerability management program. You also might highlight, at least in one of these cases, that there were a number of non-responding networks that were identified. These were networks that were in the original target list, but when we actually went to look at them using a variety of crawling techniques and so forth, they weren't able to access them, which usually means that if you have a vulnerability management tool like a Tripwire or Qualys or Tenable and so forth, those probably can't access those environments either to provide patch management updates or any of the critical vulnerability assessments that are required or mandated on these kinds of environments. So what is network situational all about, and what does Lumeta do? I mean, there are 3 phases to Lumeta network situational awareness. The first is, discovery. And we do discovery not by, again, assuming that the organization up front knows everything about what they have. There's a kernel of knowledge that you do have, but we assume that there's more. And Lumeta uses a variety of different techniques to actually crawl the network infrastructure by doing path tracing, ICMP tracing, direct host probing and interrogation, using a variety of TCP and UDP type packets, pulling route tables, layer 2 information, layer 3 information, and then stitching that all together. We have a deep level of discovery that we do of the infrastructure, which is based on what is there in fact right now. So we consider that to be authoritative. It's what's actually there. The next phase is taking that data to help the organization find meaning in it and to comprehend it more fully. And the variety of functions in our platform where we can identify cybersecurity anomalies, and some of those I'll hit on the next page in terms of what we can help the organization identify. And then from a futures perspective, clearly organizations are very concerned about how to remediate. How do I predict where there might be problems? And the idea behind the Lumeta offerings is, while we don't have all of that automated capability today, and remediation is mostly in our customers done manually, there is a vision that the networks will become increasingly self-healing, and where Lumeta's network situational awareness will be able to more automatically identify and then remediate concerns before they become bigger issues from a policy perspective or a compliance perspective. So this is a list of some of the network-based cybersecurity issues that Lumeta can help an organization identify on their network. And I know many in the cybersecurity profession know who SANS is. And the SANS have these top 20 critical security controls. And we've mapped each one of these findings, which is a capability of the Lumeta offerings, against the SANS critical controls. And I won't cover all of these, but we can identify, as I mentioned before, non-responding networks, networks that are unknown, devices that are replying to default SNMP strings, which is a no-no, leak paths between networks that are supposed to be segmented, and I think Katie mentioned some of the work that she leveraged around web infrastructure, and are looking at certificates, in particular expired certificates or self-signed certificates which might be in use within the organization. So let me just summarize with a use case. I think Katie covered a fantastic use case at Catholic Health Initiative, CHI. This is another healthcare provider that we've worked with since 2010. Their initial requirement was they wanted to discover and profile every device on the network, and they wanted to also investigate leak paths, in particular to the internet, from networks internally that were never supposed to be talking to the internet. So this organization implemented Lumeta back in 2010. The initial seed list of what they thought they had, they believed in use, was 200,000 IP addresses, and I believe that came out of an IP address management system that was in use inside the organization. After the initial use of our platform, within a week or so, we were able to identify about 300,000 total devices, and we were able to provide that organization specific fingerprinting and device profiling information. Subsequently, that organization has expanded their use, now have almost 500,000 devices and IP addresses that are under management this year. And in the future, this organization is looking at how they can leverage our offerings to do very deep analytics of something in excess of 50,000 network-connected medical instruments, this Internet of Things kind of model within their infrastructure. So I see again another example of Lumeta, and that's what we'll summarize with just as another case. So Danny, let me turn it back to you and see if there are specific questions.
Yeah, great. Thanks, Reg. That was a lot of good information. And thanks again to Skip and to Katie. We do have a couple questions from the audience that I'd like to hopefully get in before the top of the hour. I think this first question is for Skip. Skip, can you comment on how the data collected by brands like a Fitbit or an Apple device will affect the provider's networks?
It's probably in the long run going to profoundly affect the provider network. What we see is that all the major consumer companies are getting into monitoring health. So Apple is offering an offering, Microsoft is offering Health Vault, Samsung has an offering, and these consumer medical like health record repositories are also slowly penetrating the sort of porous reality of the provider networks. Even more important might be the repositories that are medical grade, that are HIPAA compliant, where we're going to see the signal data coming from patients increasing manifold, both the signal data coming from patients within the facility and the signal coming from patients who are, out doing their business in their office or at work or whatever. So the proliferation of devices that are going to be attached to the network, the number of IP connections that are going to be, coming from the mobile devices that are attaching to the network, and the importance of being able to reliably parse the signals is very important. So we see it as very important and increasingly important over the next decade. Thank you very much.
Oh, great. Thanks, Skip. That was a great answer. I think this one's for Katie. Katie, how do you use Lumeta as a vulnerability management solution?
Well, really, we use Lumeta in conjunction with our other scanning tools. So we know that we can't scan what we don't know with Rapid7 or Qualys. So what we use Lumeta for is to really understand what is changing and regularly rebaselining. So when we go to use Rapid7 or Qualys, we have the correct IP ranges to scan. It provides us with a more accurate baseline to use all of those vulnerability management tools. Also, from a compliance perspective, we're responsible to manage our network and manage what's on them. So if we don't know what's on them, it's a really bad situation when we have to find out through an incident or something like that what we should have known all along about open IP ranges that have vulnerable ports or something like that on it. So it's just critical for us to understand what our network is.
Okay, great. Thank you. And I believe this one probably is more suited for Reggie. Reggie, what are some specific learnings or concerns about identifying the shape of infrastructure on healthcare provider networks?
Okay, thanks, Danny. There are a couple of things that we've seen as we've deployed inside healthcare provider networks. I mean, one is that you really can't count on network and asset databases being correct. I mean, in our experience, they usually aren't, if they have them at all, particularly in very large and dynamic organizations where they're growing very quickly. The second thing that we see oftentimes is that there are a lot of devices that might be life critical, and they can't or shouldn't be actively interrogated, since there's a concern that some active scanning or interrogation packets might cause that device to malfunction. So the way that Lumeta has actually answered those issues is to leverage passive listening techniques in the network control plane. That means listening to traffic like OSPF or ARP traffic or DHCP traffic, which allow us to identify when those devices are coming into the network in real time, and to then be able to provide a view of when they're coming on, when they're going off, and what are they doing, just by looking at that control plane broadcast type traffic. And so that's been our answer to those scenarios when they've actually come up in healthcare provider networks.
Great, thanks, Reggie. And I think we have time for just one more, and this one looks like it's for Skip. Skip, how can we ensure that all the stakeholders, such as contractors and visitors, can use our network without risking those things that are medically necessary within our IT infrastructure and be able to communicate?
Well, and I think that's really the urgent question, right? Because and thank you, Danny, for the question, and whoever asked it. I think that the reality is that more and more is mission critical, not in terms of just, you know, whether or not your business survives, but as you pointed out, Danny, people's lives are at stake. And when your network gets in trouble, you need to be able to shut down those segments of the network which are potentially causing problems. Understanding the nature of your network and understanding which devices are on which segments of your network and which networks, so that you can quickly and efficiently quiesce elements of the network which are not mission critical when you're in trouble, is a really important thing to do. And the only way to do that is to put together these various things that we're talking about today, such that you can do it by understanding the real-time footprint of your network. So it's urgent that, you know, as you do your contingency planning around issues and problems, that you really, really, really understand how to start and shut down segments of the network when and if, you know, issues occur. For example, if you have dual networks coming in and you lose one of your telephone providers, you know, you're going to need to quickly shut down your guest access because you need that extra bandwidth that you never accounted for needing, except under contingency and so on and so forth. So what's really important is that you identify the critical assets, you identify the assets that are not critical, and you have the ability to shut down the non-critical aspects when you get in trouble.
All right, great. Thank you very much. Now that brings us to the end of the webinar. Again, I'd like to thank our speakers, Skip Snow from Forrester, Katie Winslow from CHI, and Reggie Best here at Lumeta. And everybody have a great day, and you'll be getting an email with the recorded webinar if you'd like to review it or pass it along to one of your colleagues so that they can watch it and listen to it as well. So everybody have a great day.